Children's Hospital. I am an assistant professor at FIU College of Medicine and a proud member of the ECI committee. I will be your moderator for today's first case, which will be presented by one of our senior fellows, Dr. Shrina Desai, who will be taking you right through the eye of a storm and a journey of a severe immune dysregulation of one of our patients. We are honored to have as our senior mentor, Dr. Rebecca Marsh, who doesn't need a lot of introduction to this audience since she is a very prestigious immunologist and transplant physician at Cincinnati Children's Hospital, and she's the president-elect of the CIS. So having said that, Shrina, please take it away.
Hi, good evening, everyone. Thank you, Dr. Ale, for the warm welcome. And thank you, Dr. Marsh, for being our senior expert for this challenging case. So here I present a case called the Eye of the Storm, a case of severe immune dysregulation. So here we present a 10-year-old African-American boy who came to the ER with shortness of breath, joint pain, and fatigue. He was also found to have fever, tachycardia, and hypotension. This patient was initially referred to us by our rheumatology colleagues to rule out an inborn error of immunity given his severe presentation. So, in terms of his medical history, his initial presentation was in 2020 with rheumatology, as I mentioned before, where he had an undifferentiated periodic fever syndrome. They were under the impression that he had JIA, however, workup for that was unrevealing. He also had an extensive history with multiple hospital admissions for hyperinflammatory states resembling MAS or HLH. But this specific presentation, we will be focusing on his most recent hospitalization. In terms of prior therapies, just to give you a little bit more of his background, in 2021, he was started on anakinra daily, as well as tacrolimus and steroids. During hospital flares from 2021 to the most current hospitalization, he was given pulse steroids and then maintained on steroids as an outpatient. However, in May 2022, his clinical picture worsened. And so ruxolitinib was added due to breakthrough fevers, and his labs were consistent with a persistent elevated soluble IL-2 receptor and CXCL9. In October 2023, given the severity of his HLH flares, it was decided to trial emapalumab. Emapalumab, unfortunately, had to be stopped after the first dose because he developed bradycardia, so he was switched to tocilizumab as another drug to trial. In terms of his initial physical exam, his clinical picture showed vital signs significant for fever, hypotension, tachycardia, and tachypnea. And his physical exam was pertinent for respiratory distress with decreased breath sounds at the bilateral bases, as well as lymphadenopathy that was pretty extensive. He did not have any joint or muscle tenderness or any muscle weakness. So at this point, based on the information that we know thus far, what labs should be ordered?
So I will be monitoring the chat. If you have any ideas, just please place them on the chat and I'll be, reading. Okay. Well, so far we don't have any takers, or at least I don't see any takers on the chat.
Give it another few seconds.
Ah,
Otherwise, I can move along.
Actually, someone said that the chat is disabled.
oh,
People are
yes.
putting things in the Q&A. I guess we could put lab suggestions in the Q&A instead.
Yeah, good. Thank you, Rebecca. Yeah, it could be anywhere in the Q&A, the chat, anywhere. While Sawyer help us. But in the interest of time, so we,
The
we don't.
chat should be enabled for everyone now.
Okay. Well, so far we don't have any takers on the labs, so Trina, what is that we did?
So just in the interest of time to move it along, these are the initial labs from his current admission. Of note, his triglycerides drawn at admission were 112 and they increased to 367. And his absolute neutrophil count was always elevated, as high as 47. In terms of infectious workup, his blood, urine, and respiratory cultures were negative. His respiratory viral panel was negative, and in CMV and EBV, viral PCR were also negative. In terms of specific immunophenotyping and immune workup, his basic immune evaluation consisted of a lymphocyte subset panel and immunoglobulins, which were normal. He had abnormal antigen and mitogen lymphocyte proliferation studies, as well as non-protective strep pneumotiters. But out of all of this, what was most notable was the extremely elevated CXCL9 and the IL-18. So at this point, are there any other tests to order?
So good news, the chat is working and there has been some activity. The people were asking before you showed it the IL-18. So there is genetics and with exclamation. Genetics is also coming. Unfortunately, we didn't get a serum amyloid. Um, so there is another question. Was this IL-18 from the time of presentation? So this is the time of this acute event. There is a set of IL-18s that are that Trina will be presenting to you as well.
Awesome. So to go off of that, we did obtain a cytokine panel. This was done on admission, and as you can see, there's elevation of every cytokine concerning for cytokine storm. Most pronounced is the elevation in IL-6, which is greater than 11,000. Someone mentioned genetic testing, so he actually did have prior genetic testing before this admission, in which an Invitae panel, PID panel was negative. It only revealed heterozygous VUSs that did not fit his phenotype, and whole exome sequencing was negative. We did obtain imaging during this admission as well. His CT chest was notable for consolidation in the posterior lobes bilaterally, as well as pretty extensive lymphadenopathy. His CT abdomen and pelvis showed splenomegaly, as well as concern for splenic infarcts. And he also had widespread lymphadenopathy on that imaging. To compare it, we did look back, and there was two CTs done prior. One in 2021, non-specific lymphadenopathy at that time in the chest, abdomen, and the pelvis. And then in 2022, he had enlarged axillary lymphadenopathy, as well as persistent hilar, mediastinal, and supraclavicular lymphadenopathy. And he did have a infiltrate in the right lower lobe on that imaging. We did obtain a right axillary core lymph node biopsy during this admission. The Gram stain was negative. It was negative for tuberculosis and it had a negative flow. Of note, back in September 2020, he had an excisional cervical lymph node biopsy that came back as likely reactive or inflammatory in nature. And I don't mention this on a slide, but he did have a few bone marrow biopsies, one from 2021, in which the flow cytometry was done, as well as one in 2020, that were negative for monoclonal lymphoid populations or increased blasts and was not concerning for hemophagocytic cells. And before this admission, he had another bone marrow biopsy done due to another HLH flare, which was not indicative of HLH on that biopsy as well. So what are some differential diagnoses that we're thinking of?
Okay, so the chat has been active. We are happy about that. So any thoughts about ideas of what we have so far? We're kind of giving it to you as this case kind of revealed to us on the same way. It was not straightforward. It has not been straightforward. Okay. Okay, so we have ALPS, great thought. Okay, so an autoinflammatory syndrome, Castleman's, excellent ideas, excellent thoughts. Anything else? A lymphoma, yeah, malignancy was also in our differential all the time. Okay, any other thoughts? Okay. Okay. So we have autoinflammatory syndromes, Castleman's, lymphoma, ALPS. It's interesting thoughts. Okay.
Yes, for sure. And many of which we also were thinking of as bits and pieces of this case started falling in place. We did do more infectious workup during this admission. He had negative fungal and AFB sputum cultures. His CSF culture, cytology, and meningitis panel were all negative. And we also did Carius testing, which was negative. Lastly, we did a QuantiFERON gold, which came back positive. And so I want to mention here that he did have multiple prior quant gold tests that had always resulted in indeterminate. And so when it's indeterminate, it basically refers to a failure of the positive or the negative mitogen control to elicit the expected interferon gamma response. But of note, 7 days after this positive quant gold came back, a repeat was done again, and it was found to be indeterminate again. So just to summarize all of the findings, this patient had elevated markers of inflammation across the board. He was presenting in cytokine storm. He had elevated CXCL9, and he had a positive quantiferon gold. So in terms of a diagnosis or a working diagnosis at the time was thought to be hyperinflammatory syndrome, thought to be secondary to a hidden TB infection. And that's really all that was coming back as revealing at this point for us. And so just to kind of go through his clinical course. So he was initially admitted for septic shock. He required pressors. He was also started on pulse steroids. At the time the TB testing came back positive, he was initiated on RIPE treatment, and his ferritin started to trend downwards. He was also placed on micafungin and valcyclovir, as well as PJP prophylaxis. And eventually we were able to obtain a BAL with bacterial, fungal, and AFB smears, which all remained negative. He had daily AFB sputum smears that remained negative, and with the guidance of the Department of Health, we were able to do a repeat TB PCR that came back negative. So at that point, we de-escalated his RIPE treatment down to INH and rifabutin for what we were calling latent TB. In regards to the clinical course, when his TB treatment was de-escalated to just 2 antimicrobials, we noticed that his ferritin trend actually began to increase again. And so at this point, we started anakinra, and we also had to increase his steroids. We proceeded to do the lymph node biopsy, which was negative for a lymphoproliferative disorder. And at that point, we added levofloxacin and pyrazinamide to the TB treatment again. And so it was at this point when the 4-drug regimen was escalated, that was when we noticed the ferritin trend began to downtrend again. And so that was when we were able to de-escalate or wean his anakinra and steroids. So this slide is a little difficult to read, but I did talk about that ferritin trend, and it was important in giving us some sort of clinical guidance as we were taking care of this patient. So in regards to the ferritin trend, as I mentioned, I wanted to walk you through the trend during this admission. Just to, without getting into all the little numbers here, let's start at the top right corner where he was first admitted. As you can see, the ferritin at that point was greater than 10,000. And as you move across the left side of the screen in that top row, you see the ferritin start to decrease down to 4,000. that's the point in which the TB regimen was de-escalated to the 2-drug regimen. When that happened, where the first red arrow is, you start to see that the uptrend in ferritin begins again to greater than 10,000. So in the bottom row, all the way to the right side, you see that persistent elevation in the ferritin trend at 10,000. And so then moving along again to the left, we escalated the TB regimen back up to a 4-drug treatment. And that's when the ferritin begins to downtrend again and normalizes at discharge. So just to quickly go over the pathogenesis of HLH, it can be defined as a condition involving a sustained immune or inflammatory reaction, a so-called cytokine storm. When the immune cells are excessively activated, they secrete large amounts of cytokines, notably interferon gamma, tumor necrosis factor alpha, interleukin-6, IL-10. In patients specifically with mycobacteria infection, the levels of interferon gamma, TNF alpha, and granulocyte monocyte colony stimulating factors are all higher than in those in the healthy population. Mycobacterium tuberculosis can act as an obligate intracellular pathogen in which it can do a Th1-mediated cytotoxicity, which will activate macrophages and NK cells, further releasing large quantities of cytokines. The HLH 2004 criteria, which many of you are familiar with, I'm sure, just to briefly point out here that our patient specifically met 6 of the 8 diagnostic criteria. He had fever, he had splenomegaly, cytopenias, he had elevated triglycerides, an elevated ferritin, and a soluble IL-2 receptor. So in terms of outcomes, with guidance from the Department of Health, this patient was continued on a 4-drug regimen for TB, which included rifabutin, INH, levofloxacin, and pyrazinamide. The levofloxacin was recommended by the health department for latent TB, and he initially had hyperuricemia and ethambutol. He was also continued on pentamidine for PJP prophylaxis, and we were able to slowly taper steroids and the anakinra. So in terms of the post-hospitalization follow-up, what we believe is most notable is that this patient ended up having an AFB sputum culture from early on in this admission that finally resulted as positive for Mycobacterium intracellulare, or MAC, and that didn't come back until after he was discharged. And so what we believe is important about this finding is that it's possible the MAC infection was his primary infection, as it coincided with his presentation of respiratory failure. The latent TB was likely a secondary infection that set off all these alarms in his immune system and presented itself during the hyperinflammatory period. And that was the only infection we found at the time to treat for. Supporting that was the fact that his cytokines still did not normalize, even on over 1 month of ripe treatment. In fact, they even slowly uptrended. As you can see right here in the cytokine panel, the column all the way to the right shows his cytokine panel at discharge, where you see the soluble IL-2 receptor, you see the IL-10, which are still elevated. But then 1 month post-discharge, which is a column to the left, January 11th, 2024, there's a slight uptrend in those cytokines. And so this alludes to the possibility that there was untreated MAC at that time, and we did not know about this positive finding until after his discharge. So 1 year later, which brings us to present day, unfortunately, the patient has not followed up in many, many months, over 6 months. And when we saw him most recently, he was still on very low dose steroids, as well as the 3 antimicrobials for MAC. A repeat QuantiFERON Gold was done, which was negative, and we do not have any repeat sputum or BAL cultures. Now, taking a look at his most latest labs, so 1 year post-hospitalization, we obtained his most recent cytokine panel in CXCL9. We did find out from the patient that his sister was sick about a month ago, and he started becoming ill with a mild URI about 1 week later at the time these most recent labs were drawn. And we don't have any labs, follow-up labs between June 2024 and currently March 2025. So he looked his best in terms of labs last June. And this most recent cytokine panel from a couple of weeks ago shows persistent elevation of soluble IL-2 receptor as well as IL-10. Clinically, however, the patient has been doing well. He's remained infection-free otherwise and out of the hospital for the past 1 year, which is the first since we came to know of him in 2020. Now, interestingly, this is the IL-18 trend that I was able to dig up from when he first met us in 2021 that was documented all the way to current day. So as you can see, the IL-18 that we have initially in 2021, all the way to prior to this admission in 2023, was always elevated, almost 150 to 300,000. So very elevated. When the TB treatment was initiated during this admission, that was when we first saw the most significant downtrend in the IL-18. It was to the lowest it had ever been at 6,000. Between December 13th and December 21st, which was during this admission, we saw an uptrend, which we initially thought could have been from that de-escalation of TB treatment. But unfortunately, we did not have any IL-18s that were repeated in the last year until now to see if re-escalation of TB treatment caused further downtrend. He's also been on a steroid taper and on treatment for MAC in the 1 year. And so we presume that this most recent elevation of 20,000, although it's elevated, it's not as high as it used to be. We think that it may have been due to his most recent URI, in which could have contributed to some of those elevations in cytokines, or a level of inflammasome activity that was not revealing in the past, since we always thought the elevation in IL-18 was due to an HLH flare. And so this is probably what's most important in terms of what we know now about this entire clinical picture. Does this give rise to the idea that he has an underlying inflammasomopathy?
So I will have to intervene a little bit here because this case, as we tried to present it the same way that it came to us, it was like a very slippery case that we thought we grabbed it and then it was like slipping out of our hands, and then we thought it was TB and then it was not TB and then it was MAC, and then the health department was involved, and we thought that this extremely elevated IL-18, the other inflammatory markers, were related to his HLH, MAS, in this kind of hyperinflammatory state, immune dysregulation. But now seeing it from a different perspective, the idea of him having an inflammasomopathy, which, as you know, is an inborn error of immunity caused by genetic mutations in components of the inflammasome, resulting in abnormal activity of this multi-protein complex that is found in the cytoplasm of immune cells that detects harmful stimuli and activates this set of caspase-1, specifically leading to the release of the pro-inflammatory cytokines, specifically IL-1 beta and IL-18, and the induction of cell death and proptosis. So now I think our thoughts are more leaning towards that he has an underlying inflammasomopathy that of undefined inflammasomopathy, because as you saw, none of the genetic testing that we did, whole exome and panels or anything that we tried on this patient came up with any monogenic cause. But I just wanted to say that to the audience because it has been a diagnostic conundrum for us.
So lessons learned for us is that this case underscores the challenge in diagnosing conditions like HLH, where symptoms can mimic other disorders and genetic tests may not always provide clear answers. It also emphasized the importance of always keeping a broad differential in mind and the need for continuous reevaluation of a patient's condition. And despite being on very high immunosuppressants, he still presented with cytokine storm. So his immune system was clearly setting off all of these alarms that there was an underlying inflammatory process that was not controlled. I think the eventual diagnosis of MAC illustrates this complex interplay between infections and inflammatory responses, and even the importance of considering infectious etiologies, even when you don't have necessarily positive results. I think this case also demonstrated to us the risks of opportunistic infections in patients on immunosuppressive therapy and the need for constant vigilance and regular screening for these infections, even when results may come back as indeterminate or not conclusive. And overall, this case emphasizes the need for long-term monitoring and follow-up in these complex cases. His initial treatments, based on just prelim diagnoses, needed a lot of adjustments as new pieces of information slowly started to fall in place with this patient. And I think for him, we'll never know what came first. Was it the chicken or the egg? You know, did the hyperinflammatory state or the defective inflammatory pathway come first, or did this infection come first? And so I wanted to just thank Dr. Ale for her mentorship as we worked through this challenging case, as well as our rheumatology colleagues at Joe DiMaggio, Dr. Weirs, and Dr. Lopez, who we collaborated very closely with in taking care of this patient. And then, of course, Dr. Marsh for her valuable insight. This is my third CIS webinar with her, and so it's been wonderful having you as a senior mentor to learn from.
Yeah, this is a lot of fun. And just a couple points about this case. So whenever you see significant lymphadenopathy on CT scans in the patients that either are thought to have MAS or HLH, that's always unusual. And that always bears really careful evaluation. Number one, for malignancy like lymphoma, and number two, for infections, because we do see unusual infections that then present with a secondary HLH. And atypical mycobacteria can certainly do it. Histoplasmosis can certainly do it. TB can certainly do it. There's a whole list of things. And I think, you know, some people in the chat, and Troy included, have asked, so why does this patient have MAI, right? So that needs further thinking. And so someone, JP, put in to look for NEMO, since that's going to be missed on the standard panels. That's a really good thought to look for that. The IL-18s in this case, they are extremely high. They're much higher than what we would see typically with a secondary HLH. Typically in the secondary HLH cases, you'll see much more pronounced signal for interferon gamma and things like CXCL9 and of course LIBL2 and things. But the IL-18s of 200,000s really only occur in patients with underlying inflammasomopathies that account for their MAS, so things like SJIA. And given the lung disease, that could certainly be MAI, but maybe that's a little bit of lung disease associated with SJIA. I'm not really sure, but those IL-18 levels where they were and the fact that now the patient's hanging at just 20,000 really suggests an underlying disorder that's affecting macrophage function and inflammasome function. And we've seen a small handful of SJIA patients that have had atypical mycobacterial infections. And we've always blamed them on things like ruxolitinib and anti-interferon gamma treatments, emapalumab included, et cetera. But this case, since the immune suppression was pretty light in the beginning, I do wonder if, you know, this is a signal for a disorder that's affecting two things. And so this will be really interested to continue to work up. You should try to find a good research lab to try to find a new disorder in this patient. It's super interesting.
Thank you, Dr. March. So it's 8:31, so our time is up. But I thank everybody for their attention, and the chat has been, I'm sorry I have been able to respond to everybody. It's too fast and a lot of thoughts, but I appreciate the activity of the chat. So thank you so much.
Hi, everyone. My name is Anya Lang, and I will be moderating the second half of this presentation. Just waiting for the slides to show up. Perfect. So for the second half, we will be presenting a case on deciphering immune dysregulation in an adult with severe atopic dermatitis. And so the case, again, my name is Anya Lang. I'm a clinical associate professor at the University of Washington, allergy and immunology on the internal medicine side. And the case will be presented by Alex Murray, who is currently a pediatric hem-onc fellow at Seattle Children's and University of Washington, but will actually be soon joining the fellowship as an allergy immunology fellow in our program this coming year. And we are thrilled to have Troy Torgerson as our senior mentor. Troy, of course, needs no introduction, currently director of experimental immunology at Allen Institute. So Alex, take it away.
Yeah, so we'll go ahead and get started with the case. So the title is Deciphering Immune Dysregulation in an Adult with Severe Atopic Dermatitis. So this patient initially presented, he was 38 years old, had a lifelong history of severe atopic dermatitis, and was evaluated by hematology for hypereosinophilia and had a working diagnosis of lymphocytic hypereosinophilic syndrome. His clinical presentation, he had skin erosions, erythroderma, and had been admitted to the hospital for staphylococcal and HSV-2 skin infections. And then his atopic dermatitis had been managed by dermatology, and they had really tried a lot of different therapies for him with limited success. So phototherapy, topical steroids, methotrexate, cyclosporin, and really the only thing that helped control his symptoms were pretty high dose systemic steroids. And then, of course, antibiotics and antivirals. His other medical history is significant for allergic rhinitis, mild intermittent asthma. He presented with thrombosis and was diagnosed with protein C deficiency and was on anticoagulation for that. He had chronic lymphadenopathy that was seen on imaging and splenomegaly on exam, but otherwise had no contributory family history to this case. And then on physical exam, we'll show on the next slide, but he had pretty impressive erythroderma and skin erosions that waxed and waned with these flares, and mild splenomegaly that was appreciated. So you can see this is just some area of skin involvement. He was really affected from head to toe, and it was pretty severe with this peeling erosions. So when he was first seen by hematology, their workup for hypereosinophilia included just kind of going down their algorithm. You can see his eosinophil count is quite elevated at above 13,000. This was prior to any anti-IL-5 therapy. His total IgE level was also very high at almost 37,000. And then screening for other infectious processes that may be driving this, his strongylitis IgG was negative. His tryptase level was normal. And then evaluating for any possible malignancy, they did take an inguinal lymph node that was negative and a bone marrow biopsy that was only really notable for greater than 20% of eosinophilia increased from above the normal threshold of 5%. And then myeloid disorder mutation panel was negative for PDGFRA and STAT3 mutations. They did run T cell receptor clonality, and he did have this clonal population of T cells that was identified, which leads us into our differential for hypereosinophilia that I just wanted to touch on briefly. So you can see there's two primary variants, the myeloid variant and the lymphocytic variant. Myeloid variant has PDGFRA fusion, increased tryptase, increased B12. The lymphocytic variant has this clonal population of T cells and increased IL-5 that drives this eosinophilia. And then there's various other reactive forms of hypereosinophilia, and it can also be driven by malignancy, of course, as well. And drug-induced hypereosinophilia. So this patient, it's a little bit of a diagnosis of exclusion with the lymphocytic variant, but he did have this clonal population, and so this was the working diagnosis for this patient. And clinically, it seemed to match up with some of his symptoms with this skin involvement, can have some skin involvement with LHES as well. And then at this point in time, the patient was started on anti-IL-5 therapy for treatment with mepolizumab, and then referred to immunology. And at this point in time, I just wanted to pause for any thoughts about indications for referral or next steps. And yeah, turn it over to Dr. Lang as well.
Yeah, thank you. So as you sort of please the chat, type in the chat if you have any thoughts about what possible additional workup you might be thinking at this point. I will say that the referring doctor was specifically asking for an inborn error of immunity as potential alternative explanation of the symptoms. And so far, I don't see anything in the chat.
Yeah, well, can reveal at least our first pass for this workup and see if anyone has any thoughts. So when
Oh, sorry. We got a few things here. Did we do JAK2 mutation? So that was part of the screening that he got on his bone marrow biopsy. We did not do IL-17 enumeration. And then, yeah, did you guys sequence the basic STAT3 doc8? So that's coming. So STAT3 was sequenced, doc8 was not at this point before he came to us.
Yes.
Other thoughts are STAT6 gain of function, JAK1 gain of function. Question from Troy was the STAT3 mutation done on sorted monoclonal T cells? It was not.
Okay. So jumping ahead to our first set of labs, when he came to immunology clinic, so he had absent response to vaccines. His immunoglobulin panel was notable again for that high IgE and some mild hypogammaglobulinemia. And then he had decreased class switch memory B cells on B cell phenotyping, and then B cell lymphopenia as well on his lymphocyte subset panel. He was on, I guess, a lower end of dose of steroids for him, at least when these labs were drawn, but still had some immune suppression, but not enough to necessarily explain all of what we were seeing with these abnormal values.
And so next steps.
Oh yeah, we skipped ahead a little.
It's all right, but I think we already, I mean, if there's additional comments from the audience, please let us know, but we already got questions about additional sort of genetic disorders and sequencing. So Alex can go ahead, I think, continue at this point.
Yeah, so at this point, after gathering all of this information and his clinical symptoms, a consideration on the differential was primary atopic disorders, or a kind of this group of monogenic disorders that have atopy as a significant feature, a variety of causes, and kind of trying to categorize those below. But a lot of these were already called out in the chat, but specifically this hematology physician had asked about doc8 and STAT3. And so this was something that we were thinking about, especially as it seemed to go along with what he was experiencing clinically. So just skipping ahead to his genetic testing results, we can see that interestingly, his his inborn error of immunity panel came back with this VUS and CARD11 that was heterozygous, a de novo mutation that wasn't present in his parents, and seemed to raise some interesting questions that I want to delve into further here. So first, to talk a little bit about what CARD11 does and where it is in the signaling pathway. CARD11 is a critical protein scaffold that links antigen receptor recognition with downstream NF-kappa B and mTOR signaling. You kind of see the interaction here. And that can lead to disruption of that can lead to changes in Th2 differentiation as well. So there are a variety of things that can happen to CARD11, and because of where CARD11 sits, CARD11 Oligomerization is essential for downstream signaling, and these heterozygous variants can either enhance or dominantly interfere with CARD11 function and result in different clinical phenotypes. So, for example, if you have biallelic null mutations of CARD11, it's been shown to present with a more severely affected SCID phenotype. If you have a somatic gain of function CARD11 mutation, that can be associated with hematologic malignancies like Hodgkin B-cell lymphoma. And then a germline gain of function can cause this benta, which is a B-cell expansion with NF-kappa B and T-cell anergy. So there's a clonal expansion that's initially non-malignant and then can transform to malignancy potentially. And then dominant negative mutations, which I highlighted, just seems to be going on with our patient, which permits sufficient effector function and to reveal a strong disposition towards atopic phenotypes, and also presents, as we saw in the initial labs that were done, he has a variable immune deficiency. So jumping back to our patient-specific results, so our patient had a heterozygous variant with a glycine substitution for arginine, and classified as a variant of unknown significance. However, looking back in the literature, prior functional studies showed that this particular substitution demonstrated a dominant negative effect and had decreased in vitro T-cell receptor triggered NF-kappa B and mTOR signaling in this cell transfection model. So suggesting potentially that there is a pathogenic role that this the substitution caused. And we know from other dominant negative mutations that they inhibit the NF-kappa B activation and can lead to these impaired immune responses down the road. So, there's actually other substitutions at this specific location that we can compare our patient to. So the arginine at the specific codon 75, is highly conserved, and it occurs in a functionally important area of CARD, the CARD domain, that in computational analysis show that this variant is deleterious. And there's actually a case report for this patient with different substitution at this codon 75 that has a very similar clinical phenotype to our patient. They had severe atopic dermatitis, recurrent infections, hypogammaglobulinemia, eosinophilia, et cetera. And thinking about these substitutions, so our patient had a glycine substitution, this other patient had a tryptophan substitution. They're both polar. It's plausible that they could have a similar functional effect potentially. Although with the caveat, these are extremely rare from what's been reported in NOMAD and ClinVar. But still interesting as we kind of wrap our head around what this VUS means for our patient. And thinking about the umbrella of conditions that CARD11 mutations fall under, CADIN, so CARD11 associated disseminated immune deficiency and syndromic autoinflammation is kind of the main umbrella or bucket that we think of. So we think in our patient that they have a primary atopic disorder due to this dominant negative CARD11 variant as a unifying diagnosis, with his eosinophilia, with his atopy and his immune dysregulation, and of course with his immune deficiency as well. And summarizing some of the clinical manifestations, we showed the picture of our patient before, but again, in the upper left-hand corner, you can see some of those skin erosions and HSV superinfection as well. Severe eczema, cutaneous vasculitis. Again, it's kind of a little bit heterogeneous. Our patient didn't have all of these findings, but definitely seems to share some of these phenotypic features. And then in the bottom right corner, you can see there's some hematologic malignancy associated with it as well, with cutaneous T-cell lymphoma, and then a lymph node with lymphomatous involvement as well. And these are dominant negative CARD11 mutations. So speaking more about some of the immune system defects that we see in Cadens disease. So there's defective lymphocyte activation. So we know that our T and B cells aren't mounting an adequate response to challenges with pathogens. It can be bacterial, viral, and fungal. This patient had hypogammaglobulinemia as well, and then autoimmunity and autoinflammation with skew towards Th2 differentiation, causing this atopy and eczema and systemic inflammatory features. And then another thing that we have to keep an eye on as well are the lymphoproliferative features, enlarged lymph nodes, splenomegaly, and then possibly possibility that hematologic malignancy may evolve over time as well. And then thinking more about this possible mechanism for Th2 skewing in Cadens disease. So it was recently published about dominant negative CARD11 variants that can disrupt J and K signaling, and which can cause higher GATA3 expression in T cells and preferentially cause more Th2 differentiation as well. So back to our patient. So thinking about all of these things that we put together and how we can potentially apply this knowledge that we learned to our patient. The patient was, as we had mentioned before, started on mepolizumab as an anti-IL-5 therapy, and his eosinophil count responded, but his dermatologic symptoms persisted, unfortunately. And in the interim, he continued to have several flares of skin infections and erythroderma, and was put on high-dose steroids, and he would kind of be controlled for a time, but continued to have pretty severe symptoms. He was started on dupilumab, but did not respond to that, unfortunately, either. It's worth noting that in that other case report, that patient with the substitution at the same codon was put on dupilumab and did apparently have a response to that. But and then kind of thinking outside of the box, this patient was also started on oral glutamine. And you can see, I think in that past slide, skipping back a little bit, there's a role in mTOR signaling with the glutamine there. So thinking a little bit about that, but unfortunately that did not help much either. And then more recently, he was started on a JAK inhibitor. He started on Rinvoq, and we're still kind of awaiting to see how he responds to that, but just thinking about targeting this Th2 differentiation with a severe eczema. And then he was also, of course, on prophylaxis as well, given his risk for infection with fluconazole, azithromycin, and PJP prophylaxis, and has been getting intermittent IVIG as well to help with his hypogammaglobulinemia. So kind of running through his course and what we know about him now and the treatment he's received, just wanted to open up to the audience and Dr. Lang to see if there's any other thoughts.
Great, thank you, Alex. And I think there was still some catching up with the chat. There were some additional questions about workup. Also not from Terry. Glycine is very different from tryptophan. Noted as well. And so just also more for the audience, for the background, we are still considering the diagnosis in this patient, but sort of based on the information we had up to date, we thought that the CARD11 mutation likely was pathogenic. But any other thoughts on that, please still share. Let's see. Question from Alexandra: have any of the CARD11 double negative patients been transplanted, as this disease has a pretty variable phenotype and this one seems on the sicker side? I have not seen, and please others comment as well, I have not seen reports of transplants in those patients. The most reports on treatment for the eczema that I've seen that have been successful were dupilumab in a number of patients, and obviously this hasn't worked here. And thank you, Alexandra. So none of the patient I know were transplanted either. Usually the things you've tried can be helpful, but there have been some pretty severe patients like this one. So we did not, for Terry, we did not obtain cytokine panel in this patient. That's taking notes.
Well, so can I just ask what a cytokine panel would do for you, for whoever suggested it?
Mhm. So
Can I?
thinking of treat. I'm sorry, go ahead.
I was going to say, just to ask a question, why a JAK inhibitor? What was your sort of, you know, the thinking with starting a JAK inhibitor in him, just to understand, just to walk through what you think that would accomplish in him?
Yeah, so this was not thinking of a specific the CARD11 mutation. This was really following the severe atopic refractory severe atopic dermatitis sort of pathway. So patients who would have failed dupilumab and all the things he's already failed, that would be sort of the next step. So that's really all there was to that. Without having any better idea to kind of what to target that's specific to his affected pathway.
Mm-hmm. And did his clonal T cell population go away with the treatment?
So first of the treatment has just recently started. It's too early to tell like if it's even successful. We have checked his T cells a few times since, and he always has them, though we don't have the exact information on what they are. One thought we had is perhaps they reflect like a reactive population because of his infections, but don't know.
Mm-hmm. Was there any concern? As I recall, he had a protein C variant. Am I remembering that correctly?
Correct, yeah.
I mean, what are people doing in patients that have risk for hypercoagulability, given the black box warning on the whole class of JAK inhibitors related to thrombotic events? Is anybody changing practice at all in those patients, or is there anything that you are doing differently?
I mean, so he's on warfarin. This patient has previously failed apixaban, unfortunately. So it's risk benefit discussion really, and working closely with hematology. But so yeah, monitoring his INRs and the use of this prophylactic antibiotics was also problematic in that sense. So it's definitely a very high risk situation, but yeah, we made that decision like a team approach with hematology and the patient, just because he was doing so, he is still doing so poorly.
If you did his immunophenotyping and you saw that clonal population of T cells was still present, would you consider a more T cell driven or T cell focused therapeutic approach? So, because presumably that population is most likely the population that's churning out these Th2 cytokines to drive down, to drive the eosinophilia and other things. And presumably they're probably activated in other ways as well. But thinking about something like cyclosporin or tacrolimus or something along those lines, or have you already tried that?
He was tried on cyclosporin in the past. What was the other one you mentioned? Sorry.
Tacrolimus.
Yeah.
Do you know how long ago he was started on cyclosporin?
Uh, that's a good question. It has not been recent. I mean, at least a few years. Yeah.
Because some of the initial cyclosporin formulations did not have great bioavailability. They
Mm.
particularly if he had if he had any gut symptoms associated with where he maybe had some malabsorption or something. The question of whether or not he was able to achieve a therapeutic level of cyclosporin might be posed. But anyway, just a thought, thinking about sort of what could be the primary molecular driver here.
And so other comments in the chat are perhaps mTOR inhibitor. And he has not been on that. And then Alexandra, to your point, he is on valacyclovir. Sorry, we didn't include it here, but he is on that for his HSV infections. All right.
So just to summarize, I think there's a lot of good discussion, but one of the points that we wanted to highlight by bringing up this case was that just thinking about genetic causes and severe refractory atopic disease as this patient had immune dysregulation, even in adults, he had gone his whole life with this pretty severe atopic dermatitis, and that there can possibly be a monogenic unifying diagnosis that can help us think through treatment strategies, hopefully, and find some better ways to manage his disease.
Okay, thank you so much. Great job, Alex. And Troy, thank you for your comments. Is there anything else to bring
No.
up about the case?
Good.
Okay.
Good job, Alex.
Thanks. Yeah, thanks for all of your mentorship. And special thank you to Dr. Lang and Dr. Torgerson, and then also our colleagues in hematology and dermatology, Dr. Kamat and Dr. Compton as well, who were very helpful with this case. But yeah, and thank you all
Thank
for
you,
listening.
everyone.
Yeah.
All right. Have a good rest of your day.
Yep. Thanks for everyone for attending.